So hello to everyone. We are here for a new EasyChem chat. I have the pleasure to welcome a friend from quite far from Brussels, Paul Young. Hi, Paul.
Hi there.
Nice weather. Paul is responsible for research and co-chair in a clinical part in Wellington in New Zealand, and is the Dogma ICU on Twitter. I like a lot what he says on internet, and I have the pleasure to discuss with him today about a topic that I like a lot: oxygen therapy. So, Paul, I would like to start from a question coming back with the title of a paper we signed together, co-signed together, "The Danger of Hyperoxia." So my question is, how you define hyperoxia, at least in critical illness, and which are the dangers of hyperoxia?
Yeah, so I think, there are different ways of defining it. I think in practical terms, hyperoxia really just means any exposure to oxygen that's higher, oxygen levels that are higher than normal. And I think by exposure, I would generally be talking about exposure of the cells and the tissues to higher than normal levels of oxygen. And of course, the exposure to oxygen that you get in your body when you're critically ill is not uniform. So we obviously very frequently expose the lungs to higher than normal levels of oxygen, even when that doesn't equate to achieving higher than normal levels of oxygen in the blood. Or in the other tissues of the body. So I guess we don't really know exactly whether the biggest problem is exposure of the lungs to higher than normal levels of oxygen, or exposure of some cells or tissues to higher than normal levels of oxygen. But as I say, like I personally don't think of there being a particular threshold that defines hyperoxia. The reality is that in all of the work that we do looking after people who are critically ill, we are exposing them to levels of oxygen that are a physiological stressor.
Exactly. And can I ask you whether you think that you mentioned that the threshold, of course, is difficult to define. Do you think that the duration of exposure is an issue? A patient staying 2 days in the ICU will not suffer from the same exposure than a patient staying from 2 to 3 weeks?
Yeah, so it's really hard to pull it apart, right? Because all these things are closely related to each other. So whether it's the maximum amount of oxygen that you're exposed to, or the timing of the exposure in relation to the physiological insult, or some sort of area above the curve of some threshold value, I don't know. It could be any of those things or a combination of things. I mean, I think in the practical reality in a way is that we're constantly balancing this risk of having too much or too little without actually really knowing where the zone of just right is. And that's one of the challenges that we have at the moment. So, like I think it's quite plausible that for patients who have suffered a cardiac arrest, who have a reperfusion injury, that a very brief exposure to a very high level of oxygen in the early period after reperfusion might be quite important. But on the other hand, I think it's also quite plausible that for, a patient who's got a lower respiratory tract infection, that an exposure that's really prolonged, combined with other insults, might be the thing that's important. So, it's really hard to know. And actually, I think the literature doesn't really help us a lot, because of the fact that all these things are so linked to each other, that when you try and tease them apart in any kind of analysis, you end up with stuff that's largely uninterpretable.
And we can also agree that probably, keeping a patient hyperoxemic does not make any sense when you consider the way we manage these patients, unless you think that there might be some situation, as I have some neuro preference. You think that the traumatic brain injury with, severe injury and the reserve and the reduced cerebrovascular reserve, you might tolerate or be better with the higher levels of oxygen than others. So you have any other, maybe a septic patient has cardiac arrest with a perfusion injury will be the one who is more prone to make complications to hyperoxia?
Well, I think it's pretty plausible that that the disease that you have is an important determinant of the oxygen regimen that's most appropriate, right? So I tend to agree with you that the notion that higher levels of oxygen, not extremely high, not extreme normobaric hyperoxemia, but having a PaO2 of 100 or 120 or 130 or 150, something like that. I mean, that might well be a good thing if you have an injured brain outside of that setting of a really defined ischemia reperfusion injury, because we know that the cerebral oxygen saturation can be low, and that is associated with adverse outcomes. And we know that if you give patients with low cerebral oxygen levels oxygen, that the levels go up. So, I think for that non-hypoxic ischemic encephalopathy neurologically injured group, it's plausible that a little bit more oxygen is advantageous. And actually, we have a paper which is in press at the moment, which looked at that cohort of patients in the ICU ROC study. So we looked at the people who had an acute brain pathology and took out the hypoxic encephalopathy group. And there was quite a strong signal. It's not a statistically significant signal. The sample is pretty small, but the point estimate pretty substantially favors the more liberal approach. And we found the same thing. We had a paper in intensive care medicine where we looked at the sepsis group. And there again, the point estimate quite strongly favored a more liberal approach. And I guess the way I've sort of thought about that is that, a key component of your immune system is your neutrophils. Your neutrophils do a lot of their work through an oxidative burst that requires oxygen. If you limit the amount of oxygen, you kind of limit the substrate for one of the key components of your immune system to work.
Exactly.
And so whenever you're giving people oxygen, you kind of, if you take a more conservative approach, you certainly increase the risk that you will have a period of time where the oxygen level is lower than you want it to be. And if you take a really liberal approach, you'll have a period of time where your oxygen ends up being a little bit higher than you would want it to be.
Absolutely. Clinical practice, yeah.
Now, so that's the way it is.
You made a good point, because we started from hyperoxia, and now you already introduced a very good point that if people are really keen, you say, to avoid hyperoxia in general, we're still talking about, let's say, a liberal strategy which allows, PO2 around 80 to 100 versus a conservative. So we're not talking about hyperoxia anymore, but more favoring a more conservative approach, allowing some form of, let's say, hypoxemia or very mild hypoxemia. Can you tell us I know that it's a very long discussion, all the studies that have been published, which is your practical point of view on how to interpret this data, of course, waiting the ongoing trials. How should we do in clinical practice?
Yeah, I mean, I think if you look at the way that the clinical trials have evolved in this area, we started off with the oxygen ICU trial, which, there was a very strong signal of benefit from a conservative oxygen therapy regimen. But really, if you look at that trial, it's had, I think it's about 60% of the patients in that trial were mechanically ventilated. A third of the patients had shock, and the mortality in the two groups is like 20% and 10% respectively, in a heterogeneous population of intensive care patients. And to me, the problem is that if you just think from first principles about the way in which a heterogeneous group of intensive care patients might die, the notion that half of all of the deaths could be attributable to the amount of oxygen that you're using, it just doesn't make any sense.
It's too large.
It's too large. And so that was never, there was no way that was ever a real effect. It didn't mean there wasn't a benefit, it just wasn't that big. And then the next sort of major thing that came along was the IOTA systematic review published in the Lancet, where it still looked like there was this mortality benefit from a more liberal, from a more conservative approach. But again, a third of the patients in that analysis came from the oxygen ICU trial. And of the remaining patients, just about all of them either had a myocardial infarction or a stroke. And so it's a little bit uncertain what those data meant for critically ill patients generally. And so I think after those two studies, there was kind of a momentum building where people were starting to say, well, you've really got to be very careful about exposure to oxygen, and oxygen is, it's this terrible poison, blah de blah. And I think the ICU Rocks trial sort of swung the pendulum the other way, particularly when you looked at the ARDS study, the LOCO 2 trial published at the same time, which sort of raised the possibility that there might be harm from a conservative oxygen therapy approach. And then I guess most recently we've had the HOT ICU trial, and then an additional trial in JAMA, which has kind of been down the middle. It doesn't really look like there's a lot of benefit or harm based on the point estimates.
Yeah.
And so I think where we are at the moment is, if you want to pick a thing to have a fight about, it's not oxygen. Like a liberal approach that's within the boundaries of usual care, PaO2 100, 120, something like that, or a conservative approach where you're sort of going for a PaO2 of 60 to 80. I think both of those approaches, based on the data that we have at the moment, they're pretty much, they're equivalent.
Inconclusive. Yeah. You cannot have a conclusion from that. Yes.
But
that's why you're running. That's why you're running the Megarox.
Yeah. Also. So at the same time, if you look at the confidence intervals around the point estimate for mortality, we still haven't excluded the possibility of mortality being increased or decreased by a relative margin of between 15 and 20%, which is an astronomically large effect, right? So an effect of that size for a treatment that we're giving to everyone who requires life support in the intensive care unit, that really matters. And so I don't know what the answer is. And I, as I said, I'm pretty suspicious that the answer will vary depending on what the patient pathology is.
I have this very last point, Paul, for you, because you mentioned that the point estimate, and I remember we already discussed with Jean-Louis, for example. Jean-Louis is not in favor of this randomized trial where people are randomized to one strategy on the other. Is more from individualized care. And I can share his point of view, but on the other point, what you mentioned is that for a therapy that is used basically to everyone, if you have a 1.5% absolute reduction of mortality, that would result in thousands of saved life potentially. So that's maybe a message we have to give for some therapies that is given to basically all the critical ill patients. Doing a so large trials where there is even a 1.5, 2% absolute difference in mortality makes sense in terms of large numbers.
Yeah, I mean, I think so. The other point that I would make, though, is that one of the things that is really, like, I think you can have it both ways, right? So the Megarox trial is large enough that every subgroup that we're looking at will be massively larger than any of the trials that have happened already. So we're expecting within the MegaRox trial, which has 40,000 patients, to have something in the order of 6,000 patients who've had an out-of-hospital cardiac arrest who are included. And so we actually have enough power to evaluate the hypothesis that that subgroup should be treated differently from the other subgroups. Same with the traumatic brain injury group, and same for the sepsis group. Both those two groups will have 8,000 and more than 10,000 patients respectively in them. So I think, you know, the notion of individualized medicine is okay, but the problem with making decisions that are grounded only in a physiological rationale is that large clinical trials have told us that sometimes what makes physiological sense turns out not to be true.
Exactly.
And so, like, I'm big on the notion that at the end of the MegaRox trial, we'll have a really large data set of randomized patients, and the notion that we might be wanting to use a particular oxygen regimen for a particular clinical circumstance is going to be pretty readily investigated.
Of course. Paul, I really want to thank you first for your time. It's your summer period, so you have maybe something better to do do the chat with us. No, that's of course a joke. And yeah, I really like the discussion. Of course, I hope that people from Australia and New Zealand could finally travel and come to Europe so we can meet again and have a face-to-face discussion. But in the meanwhile, thanks a lot for your participation, and I really hope to see you soon. Bye-bye.
Yeah, no worries. Thanks for having me. Bye.